Hello everyone. The topic for today's lecture is histological basis of orthodontic tooth movement. In my previous lecture, I had explained how periodontal ligament is very important for orthodontic tooth movement to take place and is therefore known as the bed of orthodontic tooth movement. Orthodontic tooth movement is observed clinically, which is the expression of various cellular and molecular changes which are occurring histologically. The type of histological change varies with whether the type of force is light or heavy. Now, periodontium is an attachment apparatus of the teeth and includes the tissue supporting and surrounding the teeth. It includes the cementum, the periodontal ligament, which forms a fibrous joint between the cementum covering the root of the tooth and the bone forming the socket wall, and this joint is known as comphosis and is exclusively present in mammals. Then the bone lining the alveolus and that part of the gingiva which is facing the tooth. So this is what forms the periodontium. Now the principal fibers of the periodontal ligament and the Sharpie's fibers can be seen in this diagram. That is, the fibers which are embedded in the alveolar bone are known as the Sharpie's fibers. Now, what are the changes which occur when light forces are applied and when heavy forces are applied? This is what we will be seeing. When light forces are applied, direct resorption takes place, and under heavy forces, indirect resorption, also known as undermining resorption, takes place. So when light forces are applied on the pressure side, vascular changes and cell differentiation from the blood vessels of the periodontal ligament takes place. There is mobilization of fibroblasts and osteoclasts. Also, there is disorganization and diminution of fiber production. And the osteoclasts, they line up the socket wall adjacent to the periodontal ligament and lie within the Hauschilp's lacunae, and resorption is initiated. After this, changes in the orientation of the bony trabeculae are seen. That is, the trabeculae which were parallel to the long axis of the tooth become horizontally oriented, that is, parallel to the direction of orthodontic force. And during the retention phase of orthodontic treatment, these trabeculae return back to normal. So it can be seen that when there is compression of the fibers, when force is applied, area of tension is pressure is created, and osteoclasts line the bone and they lie in the Hauschilp's lacunae and cause resorption or direct resorption of bone. During bone resorption, the osteoclasts attach themselves to the mineralized surface of the bone, and the following three processes occur in succession: decalcification of bone, degradation of the organic matrix, and the uptake and transport of the byproducts which are produced as a result. So resorption occurring at the advancing front and osteoclasts are also derived directly from the periodontal ligament. Hence, this is known as frontal, direct or forward resorption when light forces are applied to the teeth. What happens on the tension side when light continuous forces within physiologic limits are applied? There is stretching of periodontal ligament fibers, increased vascularity, cellular proliferation of fibroblasts and osteoblasts, deposition of osteoid adjacent to the lamina dura, reorganization of the fibrous attachment apparatus, and calcification of osteoid into mature bone. So it can be seen that the osteoblasts, they line the bone surface and form the osteoid, which later matures into bone on the tension side. Now, along with the primary bone changes, secondary remodeling changes are also taking place so that the thickness of the bone is maintained. So, when there is resorption occurring on this surface of the bone, there is deposition occurring on the outer cortical plate so as to maintain the width or thickness of the alveolar bone. This is known as secondary remodeling. When heavy forces are applied, there is reduction in the blood flow, and greater the force that is applied, greater will be the reduction in blood flow till there is blood vessels totally collapse and there is no further blood flow, which results in formation of a hyalinized zone or a cell-free zone. So, on the application of heavy forces, there is obliteration of the blood supply, and so there will be no nutritional supply to the tissue. There will be degradation of the cellular structures and a cell-free zone in the periodontal ligament, which is due to a sterile necrosis occurs, and the normal tissue architecture is lost and there is a glass-like appearance, hence the name hyaline or hyalinization takes place. The tooth movement halts until the adjacent bone has resorbed and the hyaline structure is removed and areas repopulated by cells. Peripheral areas of the hyalinized tissue are removed by invasion of cells and blood vessels from adjacent areas, and the hyalinized material is ingested by phagocytic activity of macrophages and removed. So the adjacent bone removed by cells that have differentiated into osteoclasts, and there is re-establishment of the tooth attachments. So in this you can see this is the hyalinized zone that has been formed, which is cell-free. Now, since the osteoclasts are recruited from areas adjacent to the PDL and resorb the underside of the bone immediately adjacent to the necrotic PDL, that is, resorption takes place outward from the marrow spaces of adjacent alveolar bone, and macrophages remove the necrotic material. Hence, this is known as indirect undermining or rearward resorption. When heavy forces are applied, what is happening on the tension side? There is overstretching of the PDL and tearing of the blood vessels takes place, leading to ischemia and pain in the teeth. And so, instead of osteoclastic activity starts to take place like it was occurring on the tension side. And the bone loss due to this causes the teeth to become loose in their sockets. Now, the location and the extent of hyalinization depends on the following factors. That is, how much hyalinization will take place depends on mechanical factors, that is, the nature of tooth movement, whether it is bodily or tipping, the magnitude of force, that is, whether it is heavy or light, and the rate of decay of force, whether it is applied continuously or for a short period of time. Anatomic factors like the type of bone, that is, hyalinization occurs more in the cortical, which is a hard bone, rather than the cancellous bone. And biologic factors like older people, more hyalinization occurs than in children. And various systemic conditions can also cause more hyalinization to occur. So what are the differences between frontal and undermining resorption? Application of lighter forces causes frontal resorption, whereas application of heavy forces causes undermining resorption. In frontal resorption, the forces do not exceed the capillary pressure, whereas in undermining resorption, the forces exceed capillary pressure. The cells are recruited from within the PDL in direct resorption, whereas the cells are recruited from areas adjacent to the PDL in indirect resorption. In light forces, no hyalinization is occurring, whereas heavy forces causes hyalinization to occur. Resorption is at the advancing front from the periosteal surface, so it is known as frontal resorption, whereas as resorption is at the underside of the bone from the end osteal surface, so it is termed as undermining resorption. When frontal resorption is occurring, there is a shorter lag phase of tooth movement, whereas there is a longer lag phase of tooth movement in undermining resorption. When light forces are applied, there is faster and more comfortable tooth movement for the patient, whereas there is pain on tooth movement when heavy forces are applied. So you can see in this graph that when light forces are applied, there will be a faster continuous tooth movement with shorter lag phases, whereas when heavy forces are applied, there will be periods of tooth movement which will stop till the hyalinized tissue is removed, and then again there will be a period of movement, so there is interrupted tooth movement. With light forces, there is a smooth continuous tooth movement, whereas with heavy forces, there is delay until the hyalinized tissue and adjacent bone is removed, and then tooth jumps to a new position, like I told you. Now, coming to optimum orthodontic force, that is what is the ideal force which should be applied to the teeth. It is one which moves the teeth rapidly in the desired direction with least possible damage to surrounding tissues, hence resulting in minimal patient discomfort. This concept was given by Schwartz, who said you should use light forces and the force should be close to the capillary pressure, that is the pressure within the capillaries of the tooth. If this pressure is exceeded, then this results in strangulation of the blood vessels. Hence, the optimum force is 20 to 26 gram per square centimeter of root surface area. This is the optimal orthodontic force. This causes minimal patient discomfort, produces minimal lag phase, and causes frontal resorption and maintains the vitality of the tooth. Why the use of excessive force is not advocated in OTM? Because it causes delay in tooth movement, pain and discomfort to the patient, increased tooth mobility due to removal of greater amount of supporting bone, and risk of root resorption, and greater anchorage loss. Now, coming to the phases of tooth movement, there are three phases of tooth movement: initial phase, lag phase, and the progressive tooth movement phase. Clinically, orthodontic tooth movement passes through three distinct phases. Initial phase is seen immediately after the application of force on a tooth. Rapid movement occurs for a short distance, which then stops. It occurs due to the sudden displacement of tooth within a socket in the PDL space and due to bending of alveolar bone. The extent of movement achieved is nearly same for both light and heavy forces and is around 0.4 to 0.9 millimeter in a week's time. Then comes the lag phase. This is characterized by very little or no tooth movement. It occurs due to formation of hyalinization tissue which has to be removed before tooth movement can continue. The lag phase is longer if higher forces are applied, as the area of hyalinization created is large and the resorption is undermining. Shorter duration of lag phase is noticed for lighter forces, and there is very little if any area of hyalinization and frontal resorption is noticed. Lag period is usually of 2 to 3 weeks. Post-lag phase. This phase is characterized by tooth movement at a rapid rate and as the hyalinized tissue has been removed. The movement is mediated by osteoclast and there is either direct frontal resorption of the surface facing the periodontal ligament or undermining bone resorption. So this you can see zero point 0.4 to 0.9 mm of tooth movement occurs in the initial stage. Then there is no tooth movement in the lag phase, and then tooth movement occurs rapidly after in the post lag phase. Thank you.